Welcome to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I'm Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm also the Chief of Pediatric Cardiology. Thank you very much for joining me for this 297th episode of Pediheart. I hope everybody enjoyed last week's episode in which we took a step back into time to speak with Dr. Tony Rossi of Nicholas Children's Hospital about goal-directed therapy in the intensive care unit. For those of you with an interest in cardiac intensive care, I'd certainly recommend you take a listen to Dr. Rossi last week. As I say every week, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week we move into the world of congenital heart disease and outcomes. The title of the work we'll be reviewing is Pulmonary Atresia with Intact Ventricular Septum, Midterm Outcomes from a Multicenter Cohort. The first author of this work is Ilias Iliopoulos, and the senior author John Costello, and this work comes to us from the collaborative research from the Pediatric Cardiac Intensive Care Society investigators. When we're done reviewing this paper, Dr. Iliopoulos has kindly agreed to speak with us about it. Therefore, let's move straight on to this article and then a brief conversation with its first author.
This week's work begins with some background on pulmonary atresia with intact ventricular septum and the very wide variability that is seen in this condition. And the authors explain that prior works on this topic have largely related outcomes of this condition on the degree of hypoplasia of right-sided structures, as well as coronary artery anatomy. And they acknowledge that RV-dependent coronary circulation plus coronary stenosis or other coronary anatomical variants can influence outcomes in this scenario. The authors then review how, because of the extreme variability of this condition, the surgical choices are similarly variable, with patients getting anything from a two-ventricle repair to a Fontan, or even cardiac transplant. They also may die, and we know that this is a potentially lethal condition in some anatomical variants. Because of this profound variability, an individualized approach is essential in managing these patients. The authors then explain that prior works have mostly been single-center studies, or have been larger studies but including patients from maybe as long as 2 or 3 decades ago in order to have enough patients to draw meaningful conclusions. They therefore explain that the primary objective of this work was to describe, quote, medium-term outcomes for a contemporary multicenter cohort of patients with pulmonary atresia with intact ventricular septum. We also sought to identify factors associated with attainment of each end state and evaluate the effect of RV-dependent coronary circulation and coronary atresia on transplant-free survival. They hypothesized that present-day outcomes would be improved in comparison to older literature on this topic, with a secondary hypothesis that coronary abnormalities and RV-dependent coronary circulation would have an unfavorable effect on transplant-free survival. This was a multi-center retrospective study including 19 U.S. centers affiliated with the collaborative research arm of the Pediatric Cardiac Intensive Care Society. The team reviewed records of all newborns less than 30 days of age with pulmonary atresia with intact ventricular septum admitted from January 1, 2009 till January 1, 2019. If a patient had any pulmonary valve flow or a VSD, they were excluded, as were those who had an ebstenoid tricuspid valve or severely dysplastic tricuspid valve, and these diagnoses were based on the initial echocardiograms. All sorts of data from the EMR and surgical and ICU and cath records were recorded in a REDCap database, and there was a data coordinating center confirming the data, the tricuspid valve Z-scores, the RV-dependent coronary circulation diagnosis, and other coronary diagnoses. For this work, the primary endpoint was the cumulative risk for 5 mutually exclusive states, and these were a biventricular repair, a 1.5 ventricle repair, Fontan, transplantation, and death. There's a very detailed description of the statistical analysis performed in this work, and for those interested in the multi-factor risk-adjusted models used, I would recommend going to page 848 of this work for the granular details, and as always, a link to this work is in the show notes. And on to the results. There were 295 patients in this study that included 19 centers in the United States. The median tricuspid valve Z-score was perhaps not surprisingly negative 3.06. And what about severe RV hypoplasia? Well, this was seen in 54%. RV-dependent coronary circulation was seen in 29%, and 11% had frank coronary atresia, with 5.4% having right coronary atresia, 4.4% having left coronary atresia, and 2 patients, or 0.7%, having bilateral coronary atresia. The median follow-up in this work was 4.9 years. And so what happened to these patients? Well, full biventricular repair was achieved in 15% of patients. That's only 15% of patients. 1.5 ventricle repair was achieved in 5.4% of patients. Fontan was achievable in 25% of patients. Cardiac transplantation seen in 10% of patients. And finally, and disappointingly, 18% of patients died. Looking at the cumulative risks for death in the first year, the cumulative risk of death was 11%, 15%, and 16% at 1, 2, and 6 months, respectively. Overall, the cumulative risk for death was 16.9%, 17.2%, 18.8%, and 19.5% at 1, 2, 5 years and at the very end of the study period. Tricuspid valve Z-score was inversely associated with death with an odds ratio of 0.46, and presence of coronary artery atresia was positively associated with death of transplantation with an odds ratio of 3.75. Importantly, the presence of RV coronary dependency or left coronary atresia had a significant negative impact on transplant-free survival. Right coronary atresia was not associated with worse transplant-free survival. Perhaps not surprisingly, subgroup analysis showed that increases in the tricuspid valve Z-score were associated with a greater chance of achieving a 2-ventricle repair, with a hazard ratio of 2 per unit increase in tricuspid valve Z-score, whereas RV coronary dependency was associated with a higher likelihood of heart transplantation, with a hazard ratio of 9. In their discussion, the authors state, and I quote, "In this large contemporary multicenter cohort of almost 300 neonates with pulmonary atresia and intact septum, presenting to 19 institutions between 2009 and 2019, we demonstrated improved midterm mortality compared to previous multicenter cohorts and a significant unfavorable impact of RV coronary dependency and coronary atresia on transplant-free survival. Additionally, we documented important associations between tricuspid valve Z-score, RV-dependent coronary circulation, and coronary atresia and death or transplantation. Furthermore, the relationship of tricuspid valve annulus size with the probabilities of attainment of a biventricular or univentricular end state was highlighted." The authors reference older literature showing substantially higher risks for death in pulmonary atresia intact septum from the 1980s to 1990s, suggesting that the outcomes we've reported represent significant improvement in outcomes, and also suggest that outcome improvements likely reflect improvements in care for this vulnerable population. They speak about how the decision to decompress the right ventricle is critically important when there's no RV-dependent coronary circulation if there is hope to achieve a 2-ventricle repair, and how simple decompression does not guarantee successful 2-ventricle repair, as small RVs may simply be inadequate to support 2-ventricle repair. And they speak about how the adequacy of the RV can be judged by such markers as tricuspid valve Z-score, and how prior work suggests that it is likely the best predictive tool in this regard, better than other RV measurement assessments. They explain that in this work, that when patients had a borderline Z-score and underwent RV decompression, only a single patient ultimately achieved a biventricular repair. And they mention that in this dataset, if the Z-score was greater than negative 1.6, a biventricular circulation was more likely, though not guaranteed. They reference another work that was a meta-analysis that suggested a similar rough cutoff, but remind and caution that the Z-scores are based on different datasets and standards, and one cannot definitively use these Z-scores and say that it will be the same in any given center. The investigators refer to a very nice figure, figure 4 on page 854, in which they nicely graphically demonstrate that there was a clear direct relationship between transplant-free survival and Z-score of the tricuspid valve in a logistic regression analysis, with larger Z-score tricuspid valves clearly associated with lower risk for these poor endpoints. They speak about the fact that only 15% of patients in this study achieved a biventricular repair, and how this contrasts with prior large studies where the chance was nearly twice that at 28%. They offer a few possible explanations, including possibly smaller right ventricles and tricuspid valves in this cohort, as well as the hard, strict removal of any patients who had any pulmonary valve flow in this cohort, as well as a more strict definition of what 2-ventricle repair meant. They speak about the coronary artery findings and how RV dependency enhanced the risk for transplant tenfold, and also how coronary stenosis of 2 vessels markedly increased risk for death or need for transplant threefold, but most importantly, the very poor prognosis of coronary artery atresia, particularly left atresia, and its implications for death or transplantation. They remind how left coronary atresia was especially poorly tolerated with a high incidence of death, and how it's their belief, based on these data, that an approach of listing these patients for heart transplantation who have left coronary atresia to avoid sudden cardiac death may be reasonable. They contrast this to RCA or right coronary atresia patients, who generally did far better, though about as well as those who had typical RV-dependent coronary circulation in general, and state that just fast-tracking these patients to heart transplant is likely not necessary. They point to limitations of this work, including the multicenter nature with differing approaches to patients with this diagnosis and differing biases in centers regarding optimal management. They mention also the fact that the report really went off of the cath and echo reports, and there was no actual central lab to re-review these data. Finally, they state that follow-up was relatively short or mid-term because of the contemporary nature of this work. And so they conclude, compared to prior large multicenter studies, mid-term survival is improved in this contemporary multicenter pulmonary atresia intact septum cohort, despite evidence of a generally more severe morphologic phenotype. RV coronary dependency adversely affects survival. Transplant-free survival is low in the subgroup of patients with left coronary atresia, supporting heart transplantation as treatment strategy of choice. Significant practice variation exists, limiting evaluation of optimal management strategy for patients with RV-dependent coronary circulation, with and without right coronary atresia. Further research is necessary to determine the merits of each management strategy, single ventricle pathway versus transplantation in this subgroup. Well, this work is of interest for this podcast in that we've not really discussed pulmonary atresia intact septum previously in the prior 296 episodes. This is a very complicated and heterogeneous disorder, and it's so challenging to come to general conclusions about managing this disease, given this fact. However, as in prior works, this one clearly shows that the tricuspid valve Z-score is an important association with outcome. I think the finding of left coronary atresia being a particularly malignant and dangerous form of pulmonary atresia with intact septum is very important and noteworthy, and the author's admonition that consideration for listing for heart transplant for these patients seems to be supported by the data in this work. I wonder if there are ways that we can improve these outcomes. Certainly, this must be an area where AI could be leveraged to better predict the outcomes or perhaps better inform decisions regarding surgical management. Until that time, I think some of the lessons in this work regarding the likelihood of two-ventricle repair and those who are at the highest risk for a poor outcome are important and noteworthy. At this point, I think it would make sense to move on to our conversation with the work's first author. Ilias Iliopoulos is the medical director of the Pediatric Cardiac ICU at Inova LG Children's Hospital in Falls Church, Virginia. He is a graduate of the Aristotle University of Thessaloniki in Athens for medical school. Dr. Iliopoulos completed training in pediatrics and neonatology in the United Kingdom and completed fellowship in pediatric intensive care at Guy's and St. Thomas Hospital, followed by fellowship in pediatric cardiac intensive care at the Royal Brompton Hospital and also Miami Children's Hospital, after which he was a staff cardiac intensivist at Cincinnati Children's Hospital for over a decade, until joining the team at Inova over a year ago. It is a delight to welcome Dr. Iliopoulos to the podcast. Welcome, Dr. Iliopoulos. I'm here now with Ilias Iliopoulos. Dr. Iliopoulos, thank you very much for joining us this week on the podcast.
Thank you very much for the invitation. I'm very excited to be here.
We're thrilled to have you. Congratulations to you, all of your co-investigators. You know, Dr. Iliopoulos, your work suggests that the death rates in your work, although somewhat scary with still significant mortality, are substantially lower than those described in prior works. And I'm wondering if you could speak to how these present-day results are better in comparison to prior works on this topic, and what you think are why you think these outcomes have improved in the recent era in comparison to the prior decade or two preceding this study.
Yes, thank you for the question. It is true that the outcomes we demonstrated in the recent cohort, which is the most recent multicenter study on this population, they do show a difference in both the procedural outcomes and also the medium long-term outcomes. So the hospital mortality was about 8%. That compares favorably to prior studies. 20% for the PC3 study and 33% was the neonatal mortality from the CHSS study.
Yes.
And also we saw that the procedural mortality for patients during the first neonatal hospitalization was improved even for high-risk patients, such as the group of patients with single ventricular palliation, and we have 11% inpatient mortality, which compares favorably to previous studies. Now, the long-term outcomes also have improved. There is now study that was cumulative risk of death at 5 years, about 19%, and this is a clear improvement compared to the 40 and 41% of the CHSS study and the UK population study. So I think that there is no argument that things are getting better when improving outcomes.
Yes.
Why is that? I think a number of reasons. The most important reason is the better understanding of the physiology and the different anatomic variations of these patients. It started with the seminal papers by the Boston group and Dr. Therese Zilia back in the 90s, where we realized the importance of right ventricular coronary dependency and the implications of RV decompression in these patients. It continued with the better understanding of the different anatomic substrates with the CHSS study and the realization that selective management according to anatomic substrate and size of the RV and adequacy of the right ventricular structures and not just the presence of the RV dependency is also important. And then it continued with the better understanding of the severity of the coronary anatomy for a subset of patients and the realization that some of these patients may be better served with a primary transplantation, such as the patients with left coronary osteoatresia, the patients with right ventricular dependent coronary circulation and signs of coronary ischemia. So in summary, I think we have made a lot of progress understanding the anatomic substrate and the pathophysiology of this disease, and I think we have a better decision-making and a better treatment pathways.
Well, Dr. Iliopoulos, it seems from your answer, and it's certainly been my impression, that most of the improvements that you've demonstrated in pulmonary atresia intact septum patients in terms of survival seem to have come largely from better decision-making regarding the various different anatomical substrates and details and choices regarding the pathway of care, and you very nicely illustrated for us all of the various literature over the last 25 years, starting with Dr. Gilia's paper back in Boston in the 1990s. But I know you're a very prominent cardiac intensivist, and as an ICU doctor, I wonder if you might be able to comment on what you believe has been the contribution of improvements in critical care for these patients that have helped to effectuate the results that you've described with so much improvement in survival.
Of course, the ICU contribution is very important for the management of these patients. And I will say that this is not just the ICUs, it's the entire cardiac team. We all know that for complex cardiac defects, it's a multidisciplinary team that makes a difference. So it's not just the ICU, it's the nursing, it's the imaging, it's the interventional team. And more importantly, is the collaboration and the ability of the teams to bring the expertise together for the patients that they needed at the time that they needed. And also, it's not just the interventions, but the timing of the interventions and the sequence of interventions. Yeah. So it's a team sport. It's not just ICU, but the ICU is probably a prominent player in that team. Yeah. And that's because these patients have severe, especially the patients with severe morphologic abnormalities, they require attention to detail. They require high-level monitoring, and they require interventions that are proactive and timely. And just to give an example, in our recent cohort, we had 295 patients, and we have 16 patients, or almost 5%, that they died before they received any intervention. Therefore, that percentage of patients can potentially be saved by better monitoring and better ICU care. Now, the mechanism, most of these patients died from fatal arrhythmias relating to coronary ischemia or LV dysfunction. So an ICU team that is aware and pays attention to managing myocardial oxygen balance, avoiding over diuresis, providing good sedation, rescuing the event when it happens is important to save some of these patients.
Yeah.
In addition to that, we have also shown that although the mortality outcomes are better, we still have major adverse cardiac events. About 20% of our patients that they underwent a neonatal procedure, they suffer either CPR, 13% of them, they needed mechanical circulatory support, or they had stroke, about 6% of them. So therefore, the ability of the ICU team to rescue these complications and also the level of monitor to prevent or modify factors that they can lead to this complication is very important. But I cannot underemphasize the importance of the entire team. It's not just the ICU, but ICU does play the role.
Yeah, for sure. Definitely, your words ring true about it being a team sport. And I also thought it was interesting how you discussed about oxygen delivery. You may have noticed last week we spoke with Dr. Tony Rossi about his paper in 2005 about measuring lactates. And so that type of monitoring improved over the same time period that you were studying. So I'm sure that also was one of the many different advances that improved the outcomes. Well, for those in the audience, it's fairly late as I'm speaking with Dr. Iliopoulos, who was really nice enough to speak with me so late. So I'm going to finish up with one last question, which is, although the outcomes that you described have obviously improved very substantially in the past decade or so for this disease, there still remains a very substantial degree of mortality associated with the diagnosis of pulmonary atresia intact septum. And I wondered, as someone who knows this literature and has been an active participant in caring for these patients for the past 20 years, do you believe that there is more that can be done to improve these outcomes, or do you think that we've kind of hit our maximum in terms of how well these patients can do? And if you think we can improve outcomes, where do you think most of the improvements in the future are going to come from?
Thank you for this question. I hope we can improve. There is always something we can do better. And that's not true just for the PAPS patient, but for all the cardiac effects. We're getting better with time.
Yes.
And some of it is the team function, as we discussed, the multidisciplinary collaboration. Some of it is the understanding of the different management pathways and the application of better protocols and better QI systems, better ability to rescue. I think an important element that might contribute to improvement overall is standardizing management protocols and the decision-making. In our study, we had 19 centers, and although we did not find a statistical difference on outcomes between the centers, there was a clear trend, and I think we didn't find the difference because we didn't have enough sample size from each center. Mm-hmm. And we could see that the cumulative risk of death at 5 years, for example, was ranging from 2% to 19% between the different centers. Mm. Similarly, the transplantation rates changed from 0 to 19. Mm. And we had 2 centers, for example, that they had 0 transplantation rate, and one of these centers had 5.6% cumulative risk of death, and the other center had 19%. So it's hard to explain the difference just with anatomic substrate difference and difference of patients. I think some of it is the different approach that the teams have had for these patients. Yeah. So I think as the time goes by, the understanding improves, the protocols improve, and I think with more standardization and better decision making, we will get better. Now, there are 2 additional points that I think that might also give an extra advantage. One is that the use of mechanical circulatory support. So far, the impression between many ICU physicians and in general cardiology teams are that providing ECMO support or other forms of mechanical circulatory support in these patients can be sometimes futile because there is this sort of physiological concern that by decompressing the RV, we're going to worsen coronary ischemia and it will be really hard to separate from ECMO. Now, in our cohort, we didn't see that. We had about 30% of patients that they ended up on ECMO. Sorry, 30 patients, about 10% of patients that they went on ECMO. And 50% of them survived, which is comparable to other ECMO outcomes for other cardiac disease. So I think the understanding that we can deploy mechanical circulatory support, preferably ventricular assist devices, not just ECMO, on time and rescue some of these patients and bridge them to a transplant will actually make some difference. A second important point is that we see that many of these patients, and it was clear in our study that the second part of the study, the later era, we had a lot more PDA stents for these patients, either for single ventricular palliation or for bridging to a transplant. And it does seem that although the debate between surgical sound and a PDA stent is still ongoing, and we're going to have to wait for a couple of years for the COMPASS study to have a better answer to this debate, it does seem that, at least for our cohort, the major adverse cardiac events were actually significantly lower in the PDA group, the PDA stent group, especially the subset of patients that they had severe, moderate to severe RV hypoplasia. These patients benefited, and they had less procedural complications and shorter ICU time, less time to extubate quicker. So I think there are things that we can get better.
I see. Yeah, definitely a lot of very interesting concepts. And, you know, one of the themes I think of my podcast has been over the last 6 years that standardization and protocolizing things almost always results in better outcomes. And I think you've made a very strong argument for that in this setting as well. Dr. Iliopoulos, I really appreciate your spending time with us this week to review your paper, and I wish to congratulate you and all of the many co-authors and the 19 centers that participated in this very important study. Thank you very much, and congratulations.
Thank you. It was a pleasure to be here.
Thank you. Well, I think you'll agree that Dr. Iliopoulos was quite clear in his thoughts, and he had many important comments to make. I would certainly agree that continued efforts to standardize decision-making, as in so many aspects of our care for congenital heart patients, will result in improved outcomes for this patient group. And I will reiterate that it is my hope that AI might be able to use data such as that in this work this week to help us to make these decisions in a more dispassionate and data-driven fashion. I also think that Dr. Iliopoulos' admonition of this business that we are all in, being a team sport, is one that I am sure rings true for all listening. There are so many factors that go into providing optimal care, and certainly having an important, wonderful team that works well together goes a very long way towards good outcomes. I do think that if the surgeries or the interventions are done well, it may be harder to toxify our patients, and the importance of the team may be somewhat less obvious, but there is certainly no question whatsoever that having an optimal team that has outstanding professionals from all the varied caregivers involved in congenital heart care, all working towards a common goal, is central to any good outcome. I'd once more like to thank Dr. Iliopoulos for joining us this week on the podcast and sharing his insights.
To conclude this episode of Pediheart, we hear the wonderful Italian mezzo-soprano Cecilia Bartoli singing Mozart's Alleluia from Kerschel 165, Exultate Jubilate, in a live performance from nearly 20 years ago. I think anyone hearing Ms. Bartoli's extraordinary color to her performance here will instantly know why she has been so famous and lauded the past 30 years in the world of opera. Thank you very much for joining me for this episode, and thanks once again to Dr. Iliopoulos. I hope all have a good week ahead.
Oh,